Thank you. Thank you. Thank you, Val. It gives me great pleasure to have an opportunity to come in front of you to talk about a couple of things that I am very concerned about. That's why you see all the cameras here, because we're making this presentation with the hope that we're going to use it to advocate for change both here domestically and globally. So without further ado, in lieu of land acknowledgement, which I'm sure you heard many, many, many times in this room, I'd like to use this opportunity to acknowledge the fact that the CMA has formally apologized to our First Nations friends and colleagues and family for the maltreatment that they have suffered to our hands and that they continue to suffer. I come from Buenos Aires, Argentina, and I tell you, if they were mistreated here, they were far more mistreated back at home. So I have nothing to apologize, even though I don't fully understand or know the scope of the damage, much that I have been exposed to it through my medical practice. The only thing that I find reassuring is that the work that we do is by a margin of a factor of 10 or more, impacting the lives of our friends and families in the First Nations. And for that, I'm very proud as well. My history starts in 1981, when as a young graduate in medical school doing my residency training, I was given the opportunity to come and work with Jim Hogg here at St. Paul's Hospital for a one-year postdoctoral research fellowship. HIV was arriving in North America at the same time, of course, unrelated events, and it was blossoming really in our midst, despite the fact that we didn't know what was going on. In the mid-'80s, as I moved on to my career in respiratory medicine, I was left to look after people with AIDS-related pneumocystis pneumonia again and again and again, and being a curious mind, I started to wonder how could we improve the treatment of pneumocystosis that was the #1 killer for people with AIDS in those days. And I'm not going to tell you the history, but suffice to say that we found a treatment, a cure, a prevention. We basically completed that package within a matter of a few years. And although we were very successful, we became very well known, and there was a lot more work that we could be doing. My frustration was related to the fact that my patients were going on to die regardless of my efforts because the underlying cause of the disease was not being addressed. I'll remind you that HIV itself was not identified by antiviral sinus C, François sinus C, and Montaner reported in 1984. The first antiretroviral therapy agent became available in 1986. That was ACT, and as you probably realize, ACT has now been abandoned for quite some time. It was insufficient in its ability to control the virus. So what I did is I decided to change the focus of my career to develop antiretroviral therapies. Why me? Because nobody else wanted to do it. Why here? Because I was here, and because I was given the opportunity by John Rudy, the chairman of the Department of Medicine, to be the lead junior person, if you want, for the cohort of people that we enrolled here at St. Paul's Hospital for the first time in 86 and 87 in the multi-center Canadian ACT study. That was a monotherapy study. And when we were looking at the effect of ACT on these individuals, we found to our dismay that the treatment lasted very little. And we were able to show that the reason why it wasn't lasting, it was because the virus was developing resistance to the medications reasonably quickly in a matter of weeks or months. Since I'm not trained as an infectious disease person, and I still don't want to be retrained, I actually exported the paradigm of tuberculosis management, treatment, etc., to HIV. And the reason for that was that my dad was a TB doctor. I trained with him back at home. And I always remember the story of when my dad was 25 years old, the year that I was born, he was actually being asked as a junior resident to test a very promising drug, streptomycin, in people with tuberculosis. He used to tell me, we went to the ward, and he said I was desperate, I didn't know what to do. That was clinical trials in 1956. And so he chose the sickest person in the ward, He gave this woman with tuberculous meningitis who was comatose, and they had a 0 probability of living given the standards of the time. Gave the doses of streptomycin that were available. The woman woke up, did well, but in a matter of weeks or a few months, the disease continued to progress, and eventually she died from it. Eventually it became clear that streptomycin, just like ACT, was effective for a short time in decreasing the effects of the virus, in our case, in the case of the mycobacteria, in their case, and only by adding antimicrobial potency to that regimen, they eventually managed to treat tuberculosis effectively. So I embarked on a cause of trying to find candidates for combination antiretroviral therapy. I spent a decade traveling around the world, bringing clinical trials to Vancouver, et cetera, until in 2004, I was able to, by a number of circumstances, secure access to nevirapine, the first non-nucleoside reverse transcriptase inhibitor that became available for the treatment of HIV. And at that time, the company was going to actually abandon the development of the drug. We convinced them that we had an idea that had not been tested before, namely to give 3 new drugs to people who had never been treated with antiretroviral therapy, which at the time was a totally novel idea. And we embarked on that trial. Lo and behold, the trial matured in 1995. And again, to make a very long story short, we were able to show in the yellow panel that 3 drugs could suppress viral replication in a sustained fashion. 2 drugs could not do that. We were fortunate that at the same time, Trip Gulick, a good friend based in New York, with Merck as a sponsor, they were testing indinavir, a protease inhibitor, accompanied by 2 nucleosides, and triple therapy again showed marked suppression of viral replication. All of these came out at the time of the Vancouver conference that we were organizing here in 1996. Highly active antiretroviral therapy emerged at that point, and the rest is history. We were fortunate that because we had the inside information, we were able to go to government at the time and say, listen, we have good news. They're going to come out in July. We want to start giving people this treatment right away. It was before the Health Protection Branch had approved it, before the FDA has approved it, but the circumstances were so problematic that the government decided if that's what you would recommend, that's what we're going to do. And let me remind you, this was on the strength of 2 phase 2B studies. For those of you that study clinical trials, you understand what I mean. There was not a phase 3 clinical trial done until after thousands and thousands of people were treated. Why? Because that was a priority at the time. We were fortunate because we have a very centralized program that allows us to monitor people very closely. And so we were able to show that immediately upon bringing treatment into the program, that means triple therapy, we saw a very significant decrease in the death rate, increases in life expectancy that continued to improve thereafter. And we could have been very happy and celebrate. However, we also discovered that against an ongoing rise of syphilis in the same patient population that was affected by HIV, we were seeing a decrease in the number of HIV new infections. And at the time, the prevailing understanding, scientific understanding, was that treatment could not stop viral transmission. And there were many examples in the literature from transfusion, from transplant, from whatever, that treatment was insufficiently able to transmit. However, this was the data that we had, and so we decided to explore to what extent maybe treatment was responsible for the missing HIV diagnosis that you see here. And very quickly, we were able to conclude, largely on the basis of modeling work that eventually Viviane Diaz-Lima led, that for every 1% you increase the coverage with antiretroviral therapy, or similarly, for every 1% that you increase the number of people with undetectable viral load in the community, you decrease HIV incidence in the community by 1%. We have tested that equation in the north, in the south, everywhere, and it works just the same. The next thing that we did, which I think was very important, is we asked our economics team at the time, led by Adrian Levy, and the work was done primarily by Carissa Johnston, we asked them to look at what would be the return of the investment on the vertical axis over a period of one generation if we were to increase the coverage with highly active antiretroviral therapy in British Columbia from 50% of those living with HIV to 75% of those living with HIV. And then we focus on morbidity mortality return. In other words, the prevention of morbidity mortality associated with expansion of antiretroviral therapy will give you a return on the investment that follows a sigmoid shape. And why the sigmoid shape? Because when you do return on the investment in this kind of analysis, the return has a ceiling that is dictated by the age of the cohort at the inception of the intervention. Why? Because the economists will say that after a certain age, 60, 65, whatever they want, that population no longer contributes to the same extent, and so that's why the line flattens. We then ask our economists to add to the equation the impact of the intervention on top of treatment as prevention of morbidity and transmission, now treatment as prevention of transmission. And when you add the prevention of transmission effect, the hysteresis of the curve, or the shape of the curve, changes from a sigmoid shape to an exponential shape. And when we saw that, we said, bingo, we won. Because anything that you can intervene with that gives you a return on investment of this nature goes to the front of the line. Because in other words, what he's saying is that you put this much amount of investment in this community to deal with this issue, and you will have a return for investment that will happen after we are all dead, and there is no more HIV and AIDS. The benefit will still continue to accrue. Why? Because when you treat me, you prevent the infection of my first generation cohort, and then when you do that, you prevent the infection that they could have generated, maybe 1, maybe 10, maybe 100, doesn't really matter. The more you treat, the more you actually prevent. Our friends at the United Nations and the WHO at the time, Ruben Granic and Brian Williams, took this kind of thinking and applied it to South Africa with a specific question of what would happen in terms of saving lives and saving money if we were to expand coverage with antiretroviral therapy. And so, I'll spare you the details. What they say is, look, currently we are treating people, this is at the time that they were doing the analysis, before they die, before they have a CD4 count of 200, or before or after a diagnosis of an AIDS index condition. Very, very late for our current guidelines. And so what they said is, okay, if we treat more, or if eventually everybody on the blue line, we would save 4 or 5 million lives over a period of 30 years or so. Fabulous. What happens with the money? Well, the equation is very simple. The more you treat, from the red to the yellow to the blue, the more you have to invest up front. But the more you invest up front, the sooner that peak drops and immediately it goes all the way down to the bottom. What that means is that you have a basic fixed age mortgage. Your age mortgage is the number of people that are living in your community with that condition. You have a choice. You can pay a little bit to your mortgage, and you're going to be in debt for the rest of your life, and you're going to continue debt and continue debt. The same situation that we're experiencing in this province, in this country, and the world, courtesy of our friends in the South, to a large extent. What you see here is that the greater down payment you put in your mortgage, ultimately your mortgage extinguishes very quickly. The age mortgage is here today. We need to make a decision whether we deal with it today or we're going to allow it to persist forever and ever and ever, and therefore make our investments highly inefficient. How do we move the strategy that we call treatment as prevention, because it prevents morbidity, mortality, and transmission, as well as generate savings all together at once? So how do we implement this in the real world? Well, what we can do is follow the trajectory of people within the healthcare system from the moment that they are at risk to ultimately the moment that they become viral load undetectable. You can describe as many steps in this, what we call the cascade of care, as you wish. It doesn't matter. At the end of the day, the exercise always leads you to the same place. You define your cascade of care, and then you monitor your cascade of care longitudinally, and you need to be reassured that every step of the cascade of care is getting better over time. Sometimes one is winning, the other one, the next one, but this allows you to identify where are the gaps and where you need to invest more in order to move the agenda forward. It would be remiss for me not to mention pre-exposure prophylaxis. Pre-exposure prophylaxis was first found to be effective in clinical trials by our friends in California, Grant et al. But it took a number of years to refine the strategy and, more importantly, to get social acceptability of it. In fact, still is a problem in various jurisdictions that judge pre-exposure prophylaxis as a license for people to have more sex or more risky sex. At the end of the day, what we're doing is giving PrEP to people who are at defined risk for their benefit and the benefit of society. We had long and procrastinated discussions for a long time about whether or not to bring PrEP into the province. Eventually, when Adrian Dix became the Minister of Health, kudos to him. It took me 15 minutes to convince him to move forward. He gave us the okay to go forward. We started enrolling. Junito was responsible for implementing the program. And you see that the number of people accessing PrEP in the province has continuously increased. Different to antiretroviral therapy for treatment. People who take PrEP can take it for a period of time, and then if their conjugal situation, if you want to put it that way, varies, then they may not need it. If they need it, they can go back on it. They don't need to be on it at all times. To give you an idea, the volume of data that we're handling in the center in relation to these programs, suffice to say that the HIV treatment program has now given access to treatment to 16,400 patients since 1992, which amounts to 193,000 person-years worth of data that we have within the center. For pre-exposure prophylaxis or PrEP, 14,400 individuals have received PrEP since the inception of the program in 2018. And as you can see, this amounts to 46,000 patient years of follow-up. We have two additional programs that are small and targeted. One is HIV post-exposure prophylaxis. The other one is prevention of perinatal HIV transmission. They're both working very well, but they're very small contributors to the overall picture. So I'm going to focus on treatment and PrEP only from the rest of my talk. So what have we been able to achieve by rolling out treatment as prevention in British Columbia? Basically, we have ended the epidemic as an epidemic within the province. Why? Because when we had treatment, the HIV/AIDS-related mortality rate dropped significantly by 2/3, but notice that it didn't go any further. And we were very frustrated by this, but when we thought of the potential role that treatment as prevention could have, we thought this could be the solution, and indeed it was. HIV-related mortality and AIDS-related mortality decreased very quickly to very, very low levels, something that we're very proud of. Notice that the all-cause mortality in the same cohort follows a parallel course, as you would expect, for most of this time, including up to approximately 2010, and deviates thereafter. There are three contributing reasons to that. One is the opioid crisis. The other one is COVID, and the third one is the aging of the cohort. I always make the joke, if you allow me, my HIV cohort here in the province of British Columbia, I say mine is not mine, but you know what I mean. I treat it as it was mine. We started here. Their mean age, or the median age, was my age pretty much throughout. So we're aging together, and so we're approaching the time when we may to check out for other reasons. So this is the natural history of living, and that's something that we're very proud of. With regards to incidence of HIV in the province of British Columbia, that's the green line that you see here, and basically all it's doing is declining steadily as a result of the expansion of the program, exactly as you would have expected. I should acknowledge the fact that the Americans ultimately provided us with a randomized controlled trial data to prove that we were right all along. Unfortunately, it took them at least 5 years after we implemented the strategy to basically come around and say, okay, you were right, now we're going to put it for the rest of the world. The results of the trial were impressive. They basically took a large number of individuals who were here, 1,700 or so serodiscordant couples. They look at HIV transmission. They randomize the couples to the HIV-positive member of the couple to start immediate treatment right away. The partner would have to be uninfected to be eligible to participate in the trial. The other couple was randomized to defer treatment until several clinical progression disease were met. They followed them for a period of time. At the end of the day, they were able to capture 39 events. The study was terminated ahead of time because the review board felt that the results were compelling enough and that the people that were randomized to defer treatment needed to be accessing treatment right away. Out of the 39 events of transmission that they found, 28 were genetically linked, meaning that the genotype of the person that was infected matched the genetic makeup of the virus of their partner. There were an additional number of instances, 11, where the partner that became infected with a virus that was not matching my virus, if I was the index subject, which basically indicated that they pick up the virus from a third party. Therefore, treatment as prevention could not work because obviously the guy or the woman was engaging with other partners who were at high risk. Among the 28 cases that were genetically linked, there was one case of transmission in the immediate treatment arm, and there were 27 in the delay arm. This amounted to a 96% reduction in transmission. When the study was reviewed, it was found that the single case of transmission that occurred around the time that the patient was randomized. You cannot pinpoint if it happened immediately before or immediately after the patient started antiretroviral therapy. So this serves to remind everybody that if you are going to start antiretroviral therapy and you want to prevent transmitting to somebody else, you have to wait until you are undetectable. And that's where the undetectable equal you slogan comes from. It's widely known in the community that U equals you, undetectable equals untransmissible. Once upon a time, British Columbia had the worst epidemic in the country. This is diagnosis per 100,000 population. You see them dropping, as shown here. Saskatchewan, unfortunately, has never been able to control the epidemic. And more recently, unfortunately, the direction of the epidemic in Canada is very problematic. Let me show you the data in British Columbia. As I said, in 2021, with Adrian Dix as the Minister of Health, we announced the end of the pandemic or epidemic phase of the disease in British Columbia because we have surpassed a 90% reduction in morbidity, a 90% reduction in mortality, and a 90% reduction on new infections. However, when you look at what happened subsequently, things are very worrisome. You see that in 2020, the numbers were favorable. This is the number of people entering the drug treatment program in British Columbia. It peaked in 2010. Since then, we started treatment prevention around here, and you see how this takes off, and the numbers are declining. However, there is a rebound. So with the team, Junine Toy and others in the center, we started wondering what's going on here. And quite quickly, we figured out that the majority of people that are coming into the program in the recent years are actually people who have been diagnosed elsewhere and they are already or have been already on antiretroviral therapy. That was the first clue that these are not infections that were generated in British Columbia. So Junine and her team dig up a little bit more into the data. And so if you now look at the years 2017 to 2024, which is the tail end that we're interested in, sorry. What you can see here is that we divided the population into ART-naive, people who had never been treated with antiretroviral therapies, on the pink and orange, or whatever the colors are. And you see that while the majority of people used to have BC health coverage among people who were antiretroviral therapy naive, the proportion of people with no BC health coverage has increased over time. But more concerning, among the antiretroviral therapy experienced enrollees, we have the proportion of people who had non-BC health care shown here, much more significant. So today, unfortunately, if you go back to one slide, you see that the number of people that are entering the program is actually very high at the expense of people who have been treated, but there are some who are antiretroviral therapy naive that are also migrants. And so the success of our program is currently under jeopardy because of this ongoing situation. More of that in a minute. Jeff Joy, who is also here today, has been responsible for monitoring the phylogenetic profile of our epidemic on an ongoing basis. This is something that we do routinely. Chanson is here, Sabrina is here as well. Chanson and Sabrina Broom run our laboratories. We do genotypic characterization of the virus on anybody that has a detectable viral load. Why? Because we need to know that to give you advice on what treatment would be best for you, but at the same time, we then take those data, pass them on to Jeff's team, and he does what we call phylogenetic mapping of the epidemic. What that amounts to is basically identifying the genotype of each virus that comes in, and then matching it with a database to see if that sequence matches anyone within our data set. And if they do, then you create these kind of maps. These are clusters of transmission. We identify here only the viruses in the province that have matching viruses within it. People who are not matching are not shown in this graphic chart. You see that there are different colors for different viruses, if you want. Those represent different provinces across the country, because with Jeff, we've been able to offer this service to the rest of the country, not so much because we're very charitable, but we need to know where the viruses are coming so that we can make decisions as to how to better and more efficiently deal with the epidemic. And since then, we are offering those insights to the rest of the provinces so that they can more efficiently go after the clusters, which is the real problem going forward. So using Jeff's data on a paper that we are still working on, we've been able to show since 2010 that the total number of cases in British Columbia have been declining steadily, but they seem to be plateauing in 2020, 22, and 24. But if you now look at the cluster cases on the red, cluster cases within British Columbia continue to decline, meaning that ongoing transmission in British Columbia, despite the fact that we have people coming into the province from other jurisdictions, are not transmitting. The total cases are increasing on the blue based on non-cluster cases. The point of this is that we are the only province today that has an arrangement with the government that allows us to make antiretroviral therapy for either treatment or prevention available free of charge to individuals who have no coverage. The Americans are actually currently withdrawing treatment to anybody that has no coverage, and even to those that have coverage. Imagine what a disaster they are creating for all of us. Similar situations are happening across the country, in our country. I'm going to change subject for a moment, and I'm going to share with you something that is going to become very important to understand my next set of slides. In infectious diseases, there is a concept that is very critical to understand how an epidemic is growing or not, and that's called the R0. The R0 is the effective reproductive number of an epidemic. If you have a number of people infected with a condition, and they are going to generate X number of new cases over their lifetime, that's your R0. And if the R0 is 1 or more, 1 is stable, higher than 1 means that that epidemic is growing. So we need to be very conscious at what speed the epidemic is reproducing. If you have measles, the R0 I think is 5 or 10 or something like that. It's a crazy number. It goes through a population like crazy. That's why measles is such a big problem. In HIV, the R0 is more like 1 to 2. Depending on the circumstances, so it doesn't move as fast, but it sure moves. And so what you see here is that before HAART, when the treatments were working poorly, we were operating at an R0 of 1.4. Probably before antiretroviral therapy, the R0 would have been in the order of 2. We don't have those data for British Columbia. So pre-HAART, 1.4. When we put HAART into the mix, it goes down by half, 0.7, and this is just offering HAART, not really inundating the population with HAART, if you want to use that word. But when you change the modality from a passive HAART modality to an active treatment of prevention modality, your R0 goes to 0.4. And in all honesty, I did not anticipate that PrEP would have a very dramatic effect on the R0, and I was wrong. That's generalized treatment of prevention with focalized pre-exposure prophylaxis to individuals that are at high risk actually brought that R0 down by half to 0.2. in retrospect, what I think is happening is something that is very interesting and could apply to a whole lot of disciplines. When you have a population on the red of people living with HIV, and you roll out treatment inside that's the blue, you grow that progressively, but necessarily you go from the people that are easy to access to the people that are harder to access to the people that are impossible to access. And as you go further and further, there is going to be a crescent that you just cannot find. You don't know where I can go to find these people. And we run into this problem when we're running treatment and prevention, and Jeff used to spend hours in my office trying to, what else are you going to do? And I said, I don't know, we've done everything. And the problem is that because the more recent infections, in the context of large scale-up of treatment in British Columbia, were pretty much limited to a very selected group of people that were typically young, typically not engaged with the healthcare system, typically engaging in sexual activities through mobile apps with unknown partners, it was impossible to find them. We didn't have a thread to go after them. So lo and behold, we say, you know what, we're going to implement treatment and prevention plus PrEP anyways, because that's the right thing to do. And so when you do that, treatment and prevention plus PrEP, basically what you're doing is affecting the high-risk individuals. And there may be high-risk individuals having a sexual relationship with a whole bunch of people over there, but the only people that I really care about is this crescent here, because that's the crescent in British Columbia that contains the HIV virus, untreated. And lo and behold, because we are offering pre-exposure prophylaxis based on the eligibility criteria to a group of people that is highly likely to interact with this red crescent, look at what happened. And this is what Jeff data, if you replot it as a semi-logarithmic equation, over time you find that the decline in the number of cluster cases in the province of British Columbia, it was coming down, but not in a real rush. But suddenly, when we put PrEP into the water, it took a massive nosedive. And I remind you, this is a semi-logarithmic scale. So this is very impressive. And that's where we concluded that treatment as prevention applied in a generalized fashion to population with highly selective application of pre-exposure prophylaxis are synergistic. So, as you heard in the introduction, by this time I was working to the United Nations as a special advisor on antiretroviral therapy, specifically trying to move forward the agenda on treatment and prevention. Michel Sidibe, the Executive Director of the United Nations Program, became active in that role in 2010, exactly the same year that we were coming out publicly with treatment and prevention. We had the fortune that we connected very quickly. I brought him to Vancouver during the actual Olympic Games. We organized a consultation at the time, and he was fascinated by everything that he saw. And from Vancouver, he wrote a letter to all of the agencies in the United Nations saying, you have to do, everywhere your agency is active, treatment and prevention, and it's been done in Vancouver. Several years later, he came back and he said, look, Julio, I don't know what to do. I just came back from meeting with the president of South Africa. I was riding down the elevator with Matosaledi, the Minister of Health, and I'll ask him, why are you guys not implementing treatment and prevention the way Julio is doing in Vancouver? And Matosaledi said, yeah, we're doing exactly the same. We had testing, we had treatment, we had laboratory monitoring, we have everything they do, we're doing here. And so Michel, who was not a physician, turned to me and eventually said, what are we supposed to do? How are we going to make this happen in the real world? And I said, look, Michel, what happens is that treatment and prevention is a bit like a philosophy, a religion, take it whatever way you want. And people can say that they're doing it, but you know what? They're just doing whatever they want. What we need is to apply metrics to the strategy so that people cannot pretend that they're doing what they're not doing. I said, okay. I said, well, what are the metrics? I said, well, I don't know. I had to figure it out. So I came back to Vancouver. I was in Geneva at the time. I came home. I met with Viviani, with the rest of the group. And what we did is very simple. We said, well, let's define what is going to be the end of AIDS as a pandemic concern. And I just came up with a definition. 90% decrease in morbidity, mortality, and transmission by 2030. Why? because that would be great. That you don't need anything else. And they say, okay, that makes sense. Yeah, that would be great. And we say, okay, fine. If we have a definition now, how do we figure out what intermediate steps you had to go through to get there? And since we were in 2014, 13, what we did is we took all of the BCCFE data, we pretended that we reached 90% decrease in morbidity, mortality, and transmission in 2030. So basically, we changed the axis. We back plotted the whole thing to 2015, when we were intending to announce the new targets for the global campaign against HIV and AIDS. And lo and behold, if we were to launch the campaign in 2015, by 2020, the model suggested we would require to have at least 90% of the people in the population known their HIV status, 90% of those knowing their HIV diagnosis on treatment, and at least 90% of those that knew their diagnosis and were on treatment virologically suppressed. And that's what we call the 90-90-90 target by 2020. However, the data also suggested that we needed to press on, and in order to reach the 90-90-90 decrease in morbidity, mortality, and transmission by 2030, by 2025, we should be aiming for 95% diagnosed, 95% on treatment, and 95% virologically suppressed using the same kind of approach. I'm happy to tell you that we went to the United Nations. I invited actually Stephen Harper to come with me. He kindly declined, but he told me specifically that he would not forbid me to present our data at the United Nations, for which I'm very grateful. We went, we presented the data. It was unanimously accepted by the United Nations General Assembly, and in fact, it was incorporated in the Sustainable Development Goals, where they still lie. In 2021, Antonio Guterres actually put the 95-95-95 to a vote at the United Nations General Assembly. Again, it was ratified, and it's still the two of them guiding the role of antiretroviral therapy globally. So, how is Canada doing regarding the progress towards the 90-90-90 and 95-95-95? Well, if you ask the Public Health Agency of Canada, they will send you a copy of this report that was published in 2021, I think. And they concluded that, well, Canada is doing quite reasonably well, to which we responded in an editorial that we wrote, Viviani, Diaz-Lee, and myself, that we actually don't agree. Why? Well, this is the benchmark, 90-90-90. BC has, by 2020, we have surpassed the 90-90-90 on all three domains. Alberta hasn't, Saskatchewan hasn't, Manitoba hasn't, Ontario hasn't, and Quebec hasn't. So, why do they say that we are doing well? Well, because they thought, well, you know, they're getting pretty close, except for Saskatchewan and Manitoba. Most provinces have one or two indexes above, you know, sure, that would be fine. And I said, no, this is all wrong. The whole premise of the target is to decrease incident. If we don't decrease incident cases, we remember the return on the investment curve? It's not happening. So basically, it's very inefficient. And so we wrote that editorial to explain this. HIV incident cases in British Columbia have declined, as you see here. Highly active antiretroviral therapy becomes available here. Treatment and prevention kicks in right here. The effect is obvious. HIV incident cases in the rest of Canada, except BC, there is no impact of highly active antiretroviral therapy. Why? Because we're not rolling it out at the volume that is necessary to have a public health effect. So I'm going to give you a tip. The reason why nothing is working in this province or in this country is because we're not rolling anything else at a scale. Measles vaccine, sorry, we're doing it okay, it's not good enough. Addictions treatment, nothing is working. You know why? Because we're not doing it. I can show you, and I will eventually, the cascade of cares for addiction, for hepatitis C, for syphilis, for gonorrhea, for chlamydia, they are a disaster. So we need to be above 90%, 90 for everything, in infectious diseases anyways. And the more infectious the condition, the more important it is. So let me explain you what's happening here. I'm responsible for creating this sort of 90-90-90 jingle. Why? Because I thought that, you know, that would work well, and it did. But unfortunately, the raw numbers suggested that this reflected the 90% of people we need to diagnose, which represents 81% of all people living with HIV on treatment, which represents 73% of people living with HIV to be virologically suppressed by 2020. I wish in retrospect that I would have called this the 90, 80, 70. That way I could push people further and they had less room to hide. But it is what it is. Let me show you what happens if you replot everything now according to the 90, 81, 73, which I now call 90, 80, 70. This is your target. BC is above the targets in all three domains by 2020. And now you start to see the pattern. What happens is that you can diagnose a whole lot, and you can have a 90% plus of people undetectable of those on treatment, but if this is not 90% of this is pathetic. So a 90% percentage of a 50% of people on treatment is not good enough. And so what I'm trying to illustrate here is that the only thing that matters is where this gray bar is. It has to be above 90%. Otherwise, obviously, we don't get the effect. And only BC has the 3 lines above, and maybe Ontario and Quebec are getting closer, but things are not as good as they should be. And that explains why the epidemic in Saskatchewan has never been controlled. In Manitoba, it lost control since 2020. And you might say, well, but the rest of the country is fine. No. This is 2023. Earlier this year, we had a summit with representation of all the country. We are not able to share the actual data with you because the condition for that summit was that people could share data, but confidential. Some of the provinces don't want us to talk about their numbers. But I can tell you that every province has gone up significantly since then. The Public Health Agency of Canada just released the status of HIV epidemic subsequent to the one that I just showed you. That one was for 2021 with data up to 2020. They just released the data for in 2025 up to 2023, which is pathetic because we cannot monitor an epidemic and act accordingly with data that is 2 or 3 years old. Yet in that report, they show that between 2022 and 2023, the overall number of new cases in Canada has gone up by 35%, even before what I'm going to show you next, which you're not going to like. Let's look at the rest of the world. I better rush up. This is data from UNAIDS. How is the rest of the world doing virologically? Well, not bad. Overall, the number of people diagnosed has been going up to 87%. The number of people receiving antiretroviral therapy by 2024 is 77%. Viral suppression, 73%. Boy, we're talking the rest of the world. And so how does it compare between countries and countries? Well, look at that. Kenya, Zimbabwe, Zambia, South Africa, Malawi, all of them above the 70% line. That's pretty darn good. Several other countries, I won't read them, very close. Guess who is underperforming? In the rest of the world, we have seen that the number of people that are receiving treatment has increased according to the strategy that we propose. And look at what happens with age-related deaths. They have dropped, as you would expect. Yes, of course. By 2025, we were hoping to be here, and we are not. You know what? By this much. Now is not the time to throw the baby with the bathwater. Now is the time to redouble our efforts. Why? Because HIV, I told you about age-related deaths. HIV infections are dropping. Yes, of course, we could be better, but it's not that bad. We are making very good progress, considering that this is global data, north and south of the world, all included. There is one area that unfortunately we're not doing well. This is PrEP. And I show you the synergy issue because I want you to understand that it's not just that we like to roll out PrEP for the fun of it. PrEP is synergistic. If the rest of the world could add PrEP, which is so cheap and so easy to roll out, to their effort, imagine how much closer they could be to reaching the goals that are so elusive. So, can we end AIDS? Yes. What do we need? Willpower. What do we need? Resources. What do we need? Sustainable effort. Unfortunately, we have none of that. Let's look at what is the problem. Okay. John Coyne, who is a very distinguished medical writer, he writes for Science, called this a bloodbath. the American administration is cutting funding to domestic and international health programs, right, left, and center, in a way that is criminal. And I'm not kidding. I honestly believe that. This is the terminated share of U.S. global health awards by subsector. Altogether, 80%. You might say, well, but HIV/AIDS is doing well, only 71%. This is a disaster. What this guy is doing is cutting every program that is integrated to support each other. Maternal and child health, nutrition, family planning, malaria, tuberculosis, HIV/AIDS. They all travel together. You cannot do this. This is irresponsible. And the amount that they are cutting, well, these are fully canceled. These are partially canceled. Every aspect that is relevant to our effort, everything is being devastated. So what is going to happen? Well, very simple. These are the plots that I showed you before. Remember here, we wanted to go down there? Well, this is what is going to happen. And age-related death, just the same. This is unacceptable. We spent a lifetime. I spent my whole academic career, 40 years, trying to get this bastard down on his knees. We're about to do it, and Mr. Trump is coming and saying, oh, no, by the way, you know, I changed my mind. So the United States contributes this much to global health. The rest of the countries listed here contribute approximately 60%. So if the Americans want to take the money and go somewhere else, I have some advice for them. And I'm going to give it to Mark Carney. What she just said is, if the United States no longer want to lead, Canada will. Unfortunately, the sound is not working. But nonetheless, you probably heard that more than once recently. So what we did is we sent him a letter. And we said, look, you want to lead. I'm going to show you how to lead. And what you need to do is end the fight against HIV/AIDS, domestically first, and then internationally. So we're proposing what I call the 2025-2030 plan to redouble the efforts to meet the 95-95-95 target as soon as possible to achieve the end of HIV/AIDS as an epidemic in Canada by 2030. We still can't do it, except that we need to recharge our batteries and actually do it if we want to succeed. We need to then fully fund highly active antiretroviral PrEP within pharmacare. No co-payments, no deductibles, no nothing. Everybody. We need to enhance phylogenetic monitoring of clusters nationally. We need to set up a centralized frequent reporting at PCAN, no less than quarterly. We need to harmonize risk reduction policies across the country. I don't need to tell you that risk reduction in this country is a mess. We need to address the over-criminalization of HIV transmission. And specifically, I'm talking here about the fact that a person infected with HIV today who is on antiretroviral therapy and has a sexual relationship with anybody is not going to be able to transmit. Yet, the disgruntled partner can go to the police the next day and say, Julio had sex with me and didn't tell me he was HIV positive. And the police will come and get me. I will be charged with assault, and the charge is going to stick, and I'm going to go to jail, and then I'm going to be labeled a sexual assault, whatever, for the rest of my life, with all the implications that have. And guess what? My partner didn't get infected. And in fact, he couldn't even get infected. And we discussed this with Attorney General going back to the Justin Trudeau era. I discussed it with David Eby when he was the Attorney General himself. Everybody agrees. This is all wrong. But they haven't changed it. So what good is that? Finally, we need to enhance social and medical support for priority populations. And then finally, we need to double our contribution to the Global Fund. Why? Because this is a Canadian initiative. This is a Canadian strategy. And if Canada wants to show their values, show the promise, and show that we are responsible, and we develop stuff, and then we bring it to the world to do what it's supposed to do, well, now is the time to do it. If we fail to do that, we expect an additional 6.6 million new infections, or 2,300 additional new infections per day by the end of 2029, an additional 4.2 million AIDS-related deaths, or an additional 600 new AIDS-related deaths per day by 2029. And I mean it. Failure to do this would not be an accident. It would be a crime against humanity. Thank you.